אני מאוד 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 שמחה לברך אתכם בסמינר השני שלנו של השנה. אנחנו בעצם רדפנו אחרי דוקטור דורית בן שלום כבר שנתיים, מאז שאנחנו התחלנו עם להזמין אנשים ממקומות אחרים, כי דורית ועבודתה המחקרית מיוחדות ביותר. אנחנו מדברים על בן אדם שאם הייתי קוראת את ה-CV שלה, אתם הייתם מתבלבלים מרוב תפקידים, מרוב ידע, מרוב כל מיני דברים שונים, ואני לא אעשה את זה. אני בעצם רק אפגיש אתכם עם בן אדם שיודע לקחת את הנתונים, את הדאטה, את השאלות הכי חשובות, ולהעלות ולהעלות אותנו לרמה בעצם החשיבתית. בואו ננסה להבין את מה שאנחנו רואים. ולכן באמת היא כתבה עבודות על זיכרון, היא כתבה עבודות על מערכות מוחיות, ואם באמת הייתי צריכה לתת לה איזושהי כותרת, אז הייתי אומרת על הכותרת שלה שמה שהיא זה שהיא a functional neuroanatomist. עכשיו, אם מישהו מבין את זה, זה טוב ממני. אבל מה שהיא מנסה להגיד בעצם זה שאנחנו כולנו פונקציה של היכולות המוחיות שלנו. והיום היא בעצם הולכת לדבר איתנו על הנושא שמעסיק אותה, ומבחינתי חייב בעצם להעסיק את כל אחד מאיתנו. אז אני לא רוצה לדבר יותר, אני רוצה אך ורק להעביר את הדיבור אליה. אני שוב, אם יש לכם משהו שאתם רוצים לכתוב צ'אט, דורית לא תסתכל בזה, אבל אני כן, אם אני מרגישה צורך לעצור אותה להבהרה, אני אעשה את זה ואתן לכם לדבר, אחר כך נשמור את השאלות באמת לסוף, אלא אם כן ממה שאני הבנתי מדורית, היא תסביר לכם מה מתאים בשבילהם. Dorit is going to talk in English, and I think at times we have some people who are not Hebrew speakers, but I also want to say that we can all speak in Hebrew and do anything else that works properly for us. The idea is to come together and learn. And learn we will from Dr. Dorit Ben Shalom. תודה דורית שאת איתנו.
Hello everybody, and thank you for inviting me. I'm in my garden shed because at this time of the day my cat is apt to yowl. I don't know where everyone is coming from individually, so I left a lot of time for questions. I can also take questions during the talk. The worst, speak so I can see you. Unmute so I can see you. The worst that can happen is that I tell you to wait until the question period. Right, so I'm a neuroanatomist from Ben Gurion. My lab works on the language network and on the prefrontal cortex. And today I'm going to talk to you about 2 alexithymia factors in autism spectrum disorders. And now I'm going away for a moment to bring the presentation. Just a sec. All right, where's the presentation? Okay.
For those who don't know 100% what alexithymia is, it has to do with emotion regulation, and I'm only saying that to pass the time while Dorit is getting her presentation ready. So the minute that she gets it up, I will stop talking. But alexithymia has come into the world of autism, and Dorit is going to tell us about it.
All right. So alexithymia is defined as a difficulty in describing and expressing emotions. Our group was one of the first to document alexithymia in ASD, and this is shown in those graphs. In the upper panel, you see basically that what we did is we took children with ASD between the ages of 8 and 12. And we did a classical alexithymia paradigm on them, meaning we show them emotional pictures from the International Affective Picture System. That's a standardized reservoir of emotional pictures. And we did two things with them. One is that we asked them to tell us how interesting, the other one was how pleasant the pictures were. And the other thing that we did is that we measured their skin conductance, which is electrodes that you put on 2 fingers of the hand, and they are a physiological measure of physiological stress. The important thing about those 2 measures, both the self-report and the skin conductance, is that we know what to expect from the general population. And also we had a control group of our own. The controls are in red and the people with autism are in blue. The important message of this slide is that it has 2 panels. The top panel talks about the physiological responses, and you'll just have to trust me that what this top panel shows is that there were no statistically significant differences between the physiological responses of the children with autism in blue and the children without autism in red. However, and that is the interesting contrast, in the lower panel, what you see is that the self-report measures, and I did simplify the questions completely and I asked about the picture and not about how you feel. I gave everyone the best benefit of the doubt possible. Nevertheless, as you can see from the lines crossing very much, and I have to stress that all this paper that has been cited more than 200 times by now was done on 10 children with autism, and 10 control children, so the differences are really marked. What you can see is that whereas, by the way, can everyone see my cursor, because this is a lot of the way I teach? Okay, well done. So what we can see is that in contrast to the upper panel that shows that the physiological responses were not significantly different, the self-report response, how pleasant was the picture and how interesting was the pictures, were markedly different in the children with autism in blue as compared to the children without autism in red. Taken together, the comparison between those 2 measures, the physiological measures in the top panel and the self-report measures in the bottom panel, are taken as usual to be a marker of a difficulty in describing your own emotions, because the top panel showed that the physiological emotions to be described were not very different, whereas the lower panel, which shows something about the actual description, shows that the actual description was very different. So is this gap between relatively typical emotions to be described and very atypical way to describe them, that is taken in general to be an index of a difficulty in describing emotion, that is alexithymia. Any questions about this slide? When I teach and when I have talks in small audiences, I like to make sure that every slide went through relatively okay. Any questions about this slide? All right, you can also ask questions later. So that was in 2006. the important thing about this slide is that at that time, we and many others thought that this difficulty that we were documenting, that is alexithymia, was simply an inherent feature of autism. We didn't even consider any other option. It was not on anyone's radar. However, starting about 4 years after that, that is in 2010, my good friend Jeff Bird from Oxford and his group started publishing many papers which are taken together very convincing, and they showed something very different. Basically, what they have been doing for the last 10 years is that they take non-random sampling. They collect enough people with autism and enough people without autism so that they can create similar distributions of alexithymia in the two groups. The reason that needs non-random sampling, to which we'll return later, is that on average, there are more people with alexithymia in autism than in people without autism. So if you do want to create equal distributions in the two groups, you have to throw out many of the people with autism that you have, and to throw out many of the people without autism that you have, and all together keep the ones that you want in terms of alexithymia. That has been the main research tool, I would say, in the last 10 years.
Dorit, I'm going to interrupt you for 1 minute. I'm sorry. Amit Fleece has a question that he'd like to ask you, and he didn't want to interrupt. And I would also like to say that I think that that's a really interesting methodological question, and that the question that you're raising, I think, needs to be truly focused for all of us who do research in autism. The question is, how do we test something in a group of people with autism that have more of what we're looking for vis-a-vis typically developing people, some of whom will overlap and some will not. And by throwing out some people with autism and throwing out some people with typical development, the question will always remain, is that a good methodology, and what does it tell us and what doesn't it tell us? And I think those are really important questions.
As you know, as well as I do, it's the first lesson that I tell my research student, you know, doing research is basically a balancing act, and you always gain something and you lose something. I agree that the risk here is that you get non-representative samples. And I think if that would have been the only methodology, we would all be in trouble. But I think, like everything else in designing experiments, there is something to gain from it if you are ready to combine it with insights from other experiments and other methodologies.
Thank you. Amit had a question. Amit, you want to ask a question?
Yes, my question is about the previous slide. Is the physiological...
Amit, for the benefit, not just you, for the benefit of everyone, when we talk about a slide, let me just move to that slide so that everyone see what we're talking about. Now ask your question.
So, the physiological image is about something that is not necessarily conscious, and the report should be conscious about the response to the stimulus.
Yes, exactly. But remember that alexithymia is defined as a difficulty in describing emotion. So alexithymia is defined as exactly a gap, a mismatch between what your body feels unconsciously and what you can describe consciously. So this is just one methodology of how to document whether there is such a mismatch or there isn't. Alexithymia is about a mismatch between the unconscious and the conscious. All right. So this is the methodology of Jeff Bird's group, and yes, it has advantages and disadvantages, but the advantage of it is that it can help us disentangle, to disentangle whether things that we think are inherent in autism really are. Specifically, starting at 2010, they started looking at things that we all used to think, and maybe still some of us still think, Corey, are at the core of autism, like a difficulty in recognizing emotional facial expressions or atypical empathy, definitely not lack of empathy, but atypical empathy, all right? And they start using the methodology, which has advantages and disadvantages. This slide is about an experiment about the recognition of emotional facial expression. And what here is, this is for two different emotions: disgust, anger, and surprise, fear, the distinction between within each pair. The people with ASD are full dots. The people without ASD are empty dots. And the point, the scale, the Y scale is how well they did on the recognition task, and the X is the score on the Alexithymia questionnaire, the classical Alexithymia questionnaire that they work with. And the point is that performance, as attested by those regression lines, by the lines, looks very similar. If you look here or you look there, it doesn't matter. Just focus on one of those panels and convince yourself that the line between the dots looks roughly similar, whether you are a person with autism in the full dots, or whether you are a person not with autism in the empty dots. Those are the findings. Bird's group interpretation of this is that things like a difficulty recognizing emotional expressions, facial expressions, and atypical empathy in another series of papers, not on this slide, is that things like that correlate with alexithymia. You see the line, there is a correlation with alexithymia. More difficulty, the more alexithymic you are, regardless of whether you are autistic or not. And their reasoning is that that shows that the things correlate with alexithymia and not with autism itself, because had it correlated with autism itself, we would have seen a difference between the full dots and the empty dots, and we don't. One study by itself is maybe not fully convincing, but I've been doing this consistently for the last 10 years, and other groups have replicated the findings. So it does seem that many things that we thought were at the core of autism correlate with alexithymia and not with autism. So that brings us to the question whether this alexithymia that does exist in the autism spectrum is really an inherent feature of autism, or is it rather a comorbidity? What Jeff, basically the next step that Bird and his group are saying is saying, if all those things correlate with alexithymia and not autism, that means that alexithymia itself is not a part of autism, rather another difficulty that is prevalent in autism spectrum disorder. And the technical name for that is comorbidity, but that doesn't matter. The important thing is that it's an additional independent deficit and not part of autism spectrum disorder itself. Is this clear before I summarize and move on?
It is clear, but I'm not sure that I can agree with this. If you choose your subject you choose a participant from the sample that you measure, how can you be sure that it's not related to the way you choose the specific subject?
Because you're working against your hypothesis. Basically, you're creating similar distribution of alexithymia in the two groups. And if under those conditions, the thing correlates with alexithymia, then it correlates with alexithymia.
Yeah, but I'm not saying that it's not correlated to alexithymia. What I'm saying is that maybe the way that you chose the subject, if you would choose a different subject from your group, you would got a different results.
I don't think so. It would still correlate with
It's very simple to study this. Just do a bootstrap of sampling the subject and see if you sampling other subject, it would result in different.
Fair enough, but I have been, there are two issues here. One is that I have been doing them and other groups for 10 years. So many subjects have been sampled. The other is, I forgot. I don't think it would matter. I'm sure, you know, I'm not sure that you could, I think you would get the same result, and some groups I think could do it. If you build a database of people with autism, and then you random sampled the database in order to choose your subjects. But you do want to get to an equal distribution. What would happen if you didn't do the non-random distribution is that you would still see the correlation with alexithymia. What you would lose is the not seeing the correlation with autism, because there wouldn't be a good way to compare the people with autism to the others. But
you can if you control this as a control variance.
No, you can't do control variance because there aren't enough people. Control variance can only take variance away, but it cannot add variance. What this method does is that it adds enough variance of non-alexithymic participants.
You can't reduce variance if you add more subjects.
What? No, I want to add variance. That's the thing. By doing a covariate, you can only reduce variance, never add it. We need more variance here because we need more people with autism and without alexithymia, and more people without autism and with alexithymia. There is no way in the world that I know of that by controlling variance, you could add variance. The only thing you can do is reduce variance. And we need more variance here. That's the root of the problem. All right. So the question becomes, is alexithymia an inherent feature of autism or a comorbidity? What I'll try to argue in the rest of the talk is that there are two different factors of alexithymia in autism, one of which is inherent and the other one is a comorbidity. And this of course makes it extremely hard to publish because no one wants to hear that answer. And journals just want to hear an answer whether it's that or the other. But I don't think that is true. And I'll try to argue why not in the rest of the. All right, I do know how to think about the invariant, about the inherent factor. Surprisingly, the easiest way to explain the inherent factor is through a comparison with ADHD. There is no claim here that autism is the same as ADHD, simply that there are some structural parallels, especially brain parallels, that make it easier to explain things. Specifically, one could argue, and we did argue in print, that motor hyperactivity involves this part, the blue part of the brain, whatever that is. That perceptual inattention involves the red part, whatever that is. That emotional impulsivity involves the green part, whatever that is. And there is, believe me, that there is a fourth dimension of ADHD, which isn't in the DSM, but should be, which is lack of organization. A lot of it has to do with problem sequencing stuff in order, but not only. The classical example is the child who can memorize the schedule for every day at school, but for the life of him cannot remember the order of the classes within the day. And there are many, many other examples of lack of organization in different avenues of life. We argue that the 3 dimensions from the DSM, the hyperactivity, the inattention, and the impulsivity involve these respective colored areas, and the lack of organization, which involves very specific difficulties in episodic memory, involve the yellow area, wherever that is. Any questions about that? All right. The reason this is relevant here is that perhaps surprisingly, this makes it easier to explain the corresponding areas, different areas in ASD. Okay, so basically, we have argued in print that motor dyspraxia involves, again, the blue area. The blue areas are motor, and in ASD, it's dyspraxia. The red areas are perceptual, and those have to do with sensory agnosias that are often involved also in hyper and hypersensitivities. That the memory domain involves the type of episodic memory difficulties that have been documented thoroughly by Dermot Bowler's group for many years. And that the green area, which has to do with emotion, has to do with a very specific body agnosia that is comparable to perceptual agnosia. The same, I think, one of the most beautiful description of the sensory agnosias that I know of is by the late Donna Williams, who once said, "When I was 7, I got a dollhouse, but I couldn't see the dollhouse. All I could see were the red things on upstairs and the white blocks downstairs. And this is not the time for a long discussion about this, but this is not simultaneous agnosia because the breakup is not functional. It does not break up into roof and walls. It breaks up perceptually into whatever size the individual tiles are, roof tiles are, and whatever shape, and whatever shape the bricks are." Right. So what we argued is that in the emotional, that basically that alexithymia is just a special case of a general difficulty in recognizing your body states. It is just an agnosia of your own body. And that would involve people not knowing when they're hot or cold. I actually know someone married, living independently in the Midwest in the US, who got hospitalized for hypothermia because he basically thought during winter that he was too hot, and he lowered the thermometer more and more and more in the house until he was hospitalized for hypothermia. And that involves the small children who do not know when they need to go to the bathroom. And that involves all the people who cannot go to doctors because they cannot locate pain. And I don't mean just describing whether it's a sharp pain or other types of pain. They just can't tell where it is in their body. And that makes the doctor so frustrated that no amount of social skills could rescue the interaction. So this is the type of body agnosia. And since, as Amit asked on this first slide, alexithymia has to do with giving a conscious description to your unconscious body states, if you can't do that in general, that bodes very ill for your ability to describe emotional body states like the ones that underlie basic emotions like angry, sad, and afraid. Any questions about that? So according to this picture, those two pictures taken together predict that there's at least one factor of alexithymia that is inherent to autism spectrum disorders. What I didn't know how to think about for many years is the comorbidity, the additional factor, the one that is not inherent. Jeff convinced me that it existed, but I had no leverage, no way how to think about it. And then two pieces of the puzzle became clearer in 2019. One is this piece of the puzzle from Kinerd. What we're looking at here and in the next 3 slides are the things that are circled in orange in order to reduce, the clutter. Basically, Kinerd was one of the first people to do an honest meta-analysis of all the other studies of alexithymia and ASD, so we can get an honest numerical estimate of how many of the ASD population have alexithymia. The only slide that looks like a graph is this that talks about odds ratio that says that basically if you have ASD, you're about 6 or 7 times more likely to have alexithymia than if you do not have ASD. But perhaps even more impressive are the numbers themselves. What the meta-analysis showed is that if you do not have ASD, your chances of having alexithymia hover around 4%, whereas if you do have ASD, your chances are around 49%, meaning at least for this type of population, your chances of having alexithymia are about equal to your chances of not having alexithymia. So this comorbidity, the additional difficulty, is just huge. It's about half the population. Any question about that? Given that, I think it becomes really important to ask the questions that me and I think also Corey, although I can't speak for her, really care about, which is, okay, so there is this very prevalent additional difficulty, but does it affect adaptive functioning? Does it affect everyday life? Okay, because otherwise it could be just a research curiosity. Well, the next piece of the puzzle, also from 2019, which is one of my favorite papers about ASD ever, I think, is this. It's a large-scale and thorough study of adaptive functioning in ASD. Again, we are only focusing on the part that is circled in orange. And this part is about factors that affect the general score of adaptive behavior, the general score of adaptive functioning. This column that is circled in orange has 2 important messages. One of them is positive, which is what are the things that are starred that did show a statistically significant relation to adaptive functioning, and that will get explained in a second. The other message is the negative function, the negative factor. what are all the factors that are not stars and that do not show a correlation with adaptive functioning. And again, the reason this negative finding is so impressive is because they had hundreds of subjects. It's a multi-center study, and because they checked many of what we call the usual suspects, and because they used very classical and trusted measures for each of those factors that they were testing. Those three things together mean that the negative results are really impressive. But let's start with the positive results. Interestingly, there are only three things that are starred here. Age, and this is with a minus sign that unfortunately means that in this large cohort, and this is adults, the older you are, the less well you function in the outside world. The other one with a plus sign is full-scale IQ, and we all know in any disorder whatsoever, the more intelligent you are, the better your compensatory strategies, and the more tired you will be at the end of the day. The third factor, the one that is relevant here, is right here. This SRS2 is a measure of social communication, okay? How well do you communicate verbally and non-verbally information during a social interaction? And that is a -2. So altogether, the starred version show us that age and social communication basically reduce your ability to function in the real world, whereas a higher full-scale IQ enhances your ability to function. But again, I don't think the story is complete without mentioning all the things that do not, and it is surprising, but I do trust this. One is that all sorts of measures that we know and love from the ADOS do not predict adaptive functioning. Repetitive behaviors do not predict adaptive functioning. Sensory issues, as documented by the short sensory profile, do not predict adaptive functioning. ADHD symptoms, regardless of whether they are inattentiveness or hyperactivity, impulsivity, do not predict adaptive functioning. And psychiatric comorbidities like depression and anxiety do not by themselves predict adaptive functioning. The important thing to bear about this whole column, and that this is a linear regression, meaning that all the factors are competing against each other, so you get independent contributions of each of the factors. Under those conditions, out of all these usual and sensible suspects, the only ones that do predict adaptive functioning are age, full-scale IQ, and social communication. Right, so what do we know so far about the comorbidity? We know that it's very prevalent, up to 50% of the population. And we know that social communication is one of the few predictors of adaptive functioning. But there it stopped in 2019, and I was still stuck. The last piece of the puzzle became clear in a paper that came out in October 2020. Again, what was in orange. What it says is that alexithymia, and specifically related to anxiety and depression, but what is important for our purposes is that the factor of alexithymia that is describing emotion, the one that I actually tested in 2006, basically is strongly correlated with the same questionnaire of social communication the SRS2. So now we have the full circle. Alexithymia is very prevalent in ASD, up to half of the population. It is very strongly correlated with scores on social communication. And scores on social communications are one of the very few factors, I mean, apart from age and full-scale IQ, that really determine your ability to function in the external world. So this makes the comorbid factor of alexithymia very, very important because it determines your ability to function. So now we have some description of both the inherent factor and of the comorbid factor. What this leaves open, and this is so new that it's not just that I've never even dared put it in writing, not to mention publishing it, is to start and think about the relative contribution of the inherent factor and the comorbid factor. Here, and I think elsewhere in ASD, in my professional opinion, it is vital to distinguish between mild ASD and moderate.
Dorit, you're frozen. We can't hear you.
No perfect definitions of that, but from, wait, am I muted? I don't think I'm muted.
Try again. Now do it again. You were frozen for a little bit, but now you're back. So just go right back.
But then we are lucky. But then we are lucky. I'll bring disconnected and connecting again, and that has not happened. So I feel lucky. Okay, so let me just stop the share and restart it. Because it will not start by itself. I was going to say that what we're doing on the last slide, very tentatively, but I think it's important.
Dorit, we're not seeing your screen, shared screen.
If you have internet problem, try to connect with hotspot. Maybe.
Yeah.
In my garden sheds, things are not simple here. I'm not at home.
Okay.
Stop. I can pause the share and
No, we start it. It's fine. It's fine, Dorit. It's fine.
It's fine. Okay. All right. It's either that or my heart breaks when I can't respond to my cat yowling, which we're not going to do. All right. So I think here, as elsewhere in ASD, it is vital to distinguish between mild autism and moderate to severe. I acknowledge that we do not have any useful definition that I know of this, I mean, working definition of this difference. I said that I think going by the classifiers of the DSM-5 would go some of the way, where we would put the people who need assistance as mild, and the people who need substantial and very substantial assistance as moderate to severe. I acknowledge that this is not a perfect solution, it's just the best that we have at the moment. And I would like to discuss the relative contributions of the two alexithymia factors. Since this is very preliminary, I'm only distinguishing between small and large. So don't read too much into the 1x versus the 3x's. All that it is trying to say is small versus large, and we'll get to the question mark. The inherent factor is, again, simple to think about. If we go back to the slide of the inherent factor, the same way that the dyspraxia, the sensory issues, and the episodic memory difficulties are small in mild autism and large in moderate to severe, there is every brain reason to believe that the inherent factor of alexithymia is small in mild autism and large in moderate to severe, because it's part of the same brain system and they behave similarly. So that leads me to the conjecture that the inherent factor of alexithymia is small in mild autism and large in moderate to severe. The comorbid factor, on the other hand, I think is large in mild autism. And the reason I think so is that basically all the papers in Kinerd and most of the subjects in Tillman, and as far as I can see, almost all the subjects in Oakley have mild autism. Again, no one quantifies it like this, but some rules of thumb usually hold, and I mean usually. If you see full scale IQ that is about 100, it is usually mild autism. As soon as you start, my study at Johns Hopkins was different because this is a tertiary referral center and the average full scale IQ of my group was 93. So I think I had some moderate autism children there also from knowing them. But so if there's no other evidence, I go for average full scale IQ as a rough measure. There are also other indications, say that the Tillman study, or say Oakley study and the Tillman study were mild autism because the Tillman says that they had to take out many people out of that sample because they couldn't do, those are adults, and the ones with full scale IQ of 75 found it hard to do some of the questionnaires that they were doing. So I think there are very many practical reasons to think that almost all the subjects at Kinerd, almost all the subjects at Tillman, and I think all the subjects at Oakley more or less were mild autism. So if that is true, that means that this impressive comorbidity of 50% is for mild autism. So the situation that my guess is that the situation that we're looking at, and this is why it's so confusing, is that in mild autism, what you mostly see is the comorbid alexithymia, whereas in moderate to severe, what you mostly see is the inherent factor. And then again, related to Amit's question, I think it's fair to say that we have no idea about the size of the comorbid factor in moderate to severe, because the usual way to do the comorbid factor is by self-report, and a very difficult self-report. The TAS is not an easy questionnaire. This is not what I did. I did it in another way, but this is not the comorbid literature. So I really think it would, I'm not saying it's impossible to test the comorbid factor in moderate to severe. I'm just saying that as far as I know, none of this has been done. So I'm just listing it as a question mark. Nevertheless, even with this question mark, I think the picture, my hypothetical picture, is very clear. When you work with mild autism, you will mostly see this Kinerd 50% of alexithymia. When you move to moderate to severe, you'll see a lot of the body agnosia that results in the inherent factor. Because to remind you, that would be the people who also have moderate to severe dyspraxia, moderate to severe sensory issues, and moderate to severe episodic memory problems. So there's every reason to assume that they also have moderate to severe body agnosia that would result in the inherent factor. And that is basically it. Any questions about this slide before we go back and do questions about the other slides?
I would like you to clarify, perhaps for us all, what the difference of body agnosia, alexithymia, and your other factor alexithymia is. I think that definition was not made clearly enough. And so,
all right, no problem. I'll talk about body agnosia in a second. Comorbid alexithymia is the classical alexithymia. My claim is that the inherent factor is a consequence of body agnosia. Think about it, Corey. If a child or an adult cannot read their body to the extent that they can't locate pain, that they can't tell sometimes if they're hot or cold, but in a systematic way, not every once in a while, and all other body states, they need to find compensatory strategies to know if they're tired. All of those things, the difference, and this is one of the few things that Baron Cohen was right about, between basic emotions and social emotions is that basic emotions like angry, sad, and afraid are, as Amit said, interpretations of unconscious body states, as opposed to social emotions like ashamed or embarrassed that do not have this close correspondence to body states, okay? This is the classical distinction between social emotions and basic emotions. However, there is this chain of commands. If you can't even read your body states that are not emotional, like tired or pain or in pain, or those are people who do not know sometimes when they are in pain. You get very atypical in the magnitude of no response to strong pains, sometimes big responses to mild pain. It's all, there's a great difficulty in reporting pain in general. If those body states are not being brought to consciousness in a useful way, right? That means that the body states that underlie sad, afraid, and angry are also not described, not brought to consciousness well. So that means you necessarily have alexithymia to basic emotions. And I think developmentally, but that is your domain, a child who cannot do basic emotions does not stand much of a chance of doing social emotions well, because developmentally that's a stepping stone. So it starts with not being able to read your body for non-emotion in general, or for all states, emotional or not. But that would preclude the development of a normal describing of emotional states that lead to basic emotions. And that in turn would prevent the stepping stone to developing typical social emotions. So I am only talking about the body agnosia and the comorbid alexithymia, but the body agnosia, I think, invariably leads to alexithymia. I don't see any other route, basically. I think if you have a moderate to severe, remember, a moderate to severe body agnosia, you will have a moderate to severe alexithymia. I don't see a way to escape that, apart from very, very complex compensatory strategies that require a huge amount of full-scale IQ.
So, Dorit?
Yes.
Very interesting talk. Thank you. So you would say that the inherent factor is, the origin of the inherent factor is the body agnosia?
Yes.
And do you think that the comorbid alexithymia has a different origin?
Absolutely. I think, well, you know, if it walks like a bird and talks like a bird, the comorbid alexithymia in ASD, the one that is documented by the meta-analysis of Kinerd, so far looks the same as comorbid alexithymia everywhere else in psychiatry, like in eating disorders, even the ones who are not comorbid with ASD, okay? Anxiety, depression, anywhere you look in psychiatry, there is comorbid alexithymia. And so far, it looks very much like the one in ASD. I do think we would see, you do see a little bit of the inherent even in mild. It does not bring you to the clinical cutoff, okay? What brings you to the clinical cutoff, in my opinion, is the comorbid one, and it really looks like the general comorbid alexithymia. And yes, there is a general big question in psychiatry, where does all this comorbid alexithymia everywhere in psychiatry comes from? And no, I do not know the answer, but this large factor, the 50% so far, looks very much like comorbid alexithymia everywhere, anywhere else in psychiatry.
But do we have any knowledge that will lead us to think that the origin is different? I mean, can it be only the degree of the alexithymia?
No, I don't think so, because those are people who do basic, you know, that's the old Baron-Cohen generalization. If you look at it from the right direction, he has always worked with people with mild autism. And his group starting always, the reason he fixated so much on the contrast between basic emotions and social emotions is that in his group, which is mild autism, people are reasonably good at basic emotions and bad at social emotions. I mean, he set a lot of his career on this gap, on this contrast. The inherent fact, body agnosia would kill basic emotions, all right? So I know for sure, in as much as I know anything here, my guess is that this is a totally different route, and I don't think we know it in general in psychiatry, but I think I know that it is not body agnosia.
But I think that Yonat is actually asking if you have not just that it's a different construct, can we associate it in the brain to a different place than that green place?
Oh, you want brain? Okay, I give brain guesses, no problem. This is my job, is to give brain guesses.
Was I correct in that, Yonat?
Yes, it's always interesting to know the origin in the brain as well, but I was also wondering if we have any other hypotheses about the origin, because it seems quite clear that you have an idea about the inherent.
No, I don't. My best brain guesses are this. All right. One of the reasons it was so hard to build a functional anatomy of this brain system is that the green area is an area of emotional output. So it's connected to the insula. Emotional input in the mammalian brain does not go to this area. It colors the perceptual area. So the perceptual area here is connected to the amygdala. Now, the question of whether the comorbid alexithymia has to do with connections between the prefrontal cortex and the insula, or prefrontal cortex and the amygdala, probably the insula. Okay, we have enough time. How can I explain it efficiently? Traditionally, there are two types of alexithymia, none of which is our two. One alexithymia basically has to do simply with less emotional states, less unconscious emotion in your body, and that leads to sociopathy, rather than to ASD at all. And that is relatively rare. This is called alexithymia type 1. Alexithymia type 2 has to do with the emotional states are there in the body, but the insular maps are weaker. That's, I think, is the comorbid one, and that's the one that Bird is finding in his mild autism subject. The one, I think the inherent one is not about the insula. The inherent one is about how the insula is read by the prefrontal cortex. So that should be Alexithymia type 3, but no one has talked about it yet in that way. So yes, I would say that within autism, the inherent factor is probably prefrontal, whereas the comorbid one is insular. That would be my best guess. And I once gave Jeff a title to think about it. He said he would use it. I don't know if he did. Do they have less to describe, or do they describe less? Right. So those are, you're welcome. Anyone else asking questions about any? I was trying to be organized and finish this slide before going back, but I'm ready to answer any questions that I can try to answer, basically.
Yes, can you differentiate it clinically? When you see a child, can you describe or differentiate between the two alexithemias in his behavior or whatever, clinically?
Well, I could try. It's a good question. Remember that, let me just remind you, all of you first, about the state of research. It's not only that I cannot yet publish about the fact that there are two factors. I cannot yet publish about the fact that there is an inherent factor, because everyone is expecting the comorbid. So our cumulative knowledge of a community is very, very, very small, because the discussion is still not there. You know, we're about 10 steps ahead of the discussion. But my guess would be, first of all, I would predict to see the inherent factor more in moderate to severe and the comorbid in mild. But in terms of clinically differentiating, maybe going back to Yonat's question, if it doesn't come with body agnosia, then it's probably the comorbid. That would be my rule of thumb. And body agnosia is easy to see. Those in children especially, those are the children that don't know when they need to go to the toilet. Those are the children who don't know when they're hot or cold. And I don't mean the subjective. I mean when, like the person who got hypothermic, they don't know and their body is really cold. It's not about the different, different feelings. The children who can go to school on a cold day with too little clothes and shiver. So it's not a question of whether they don't, how they interpret, they shiver, they can get sick, the body is clearly cold and the child doesn't know it. Those are the people who, as I say, can even if they have good social skills, cannot go to doctors. At least not to, because the doctor would ask, does it hurt? And then they would ask, where does it hurt? And then they would ask what type of pain. And a person with moderate to severe body agnosia cannot answer any of those questions. That leads the doctor-patient interaction to break down, I assume because the doctor feels very helpless and, so body agnosia is not, it's just that we don't have as far as I know, we don't have a good criteria for that or a similar disorder in the DSM, but we could make it up. It's not easy, it's not hard to diagnose. The only thing is that, think numerically, mild autism is, I mean, we can argue, but it's about 1% of the population, give or take. My guess, moderate to severe is much, much less, 1 in 1,000 perhaps. So you are much more likely in the clinic, well, depending what type of clinic you run, but in a general ASD clinic, you are much more likely to see the mild cases than the moderate to severe. Any other questions? Yes, Amit. But Amit, just a second, Amit. But Amit was lucky because I can see his hand and most of you are below my screen. So that goes back to this funny speak so I can see you. Just speak and then you pop up into my screen. Yes, Amit.
About the adaptivity and
let me bring the slide.
No,
Okay.
this.
I know, but I want everyone to see it, not just you. Yes.
It's about this. I mean, there is any variable about motorics or something like this, or not in this research?
Not in that. My guess is, but it's just a guess, that since the sensory issues did not make a difference, the motor issues would probably not as well, because my and others' guess is that a lot of the motor issues in ASD have to do with impaired proprioception, and that is usually in correlation with other sensory issues. What I mean is that I usually see people, sensory, and not always, but sensory and motor difficulties are often correlated, and since the sensory stuff did not show, I don't know. I suspect not, but you are right, that is not one of the things they measured.
I have two questions that I'm going to ask for another participant who cannot ask them for herself right now. And I believe that they're both quite good. I'll start with one that I think is just a matter of knowledge, and that is, do we have percentages of alexithymia in those other psychiatric conditions that you spoke about? How much alexithymia is there in ADHD, in depression, in anxiety, so that we can get a sense of alexithymia over the conditions?
I don't have the numbers. My impression, I would need to look it up. My impression is that it's quite high in anorexia nervosa and less high in other disorders, but still much higher than you would anticipate. But I wouldn't expect 50%, perhaps in anorexia. And then the key question is that you need to take the anorexics who are not ASD in order, right? But it's still high there. So, right, but what underlies, so no, I haven't done the footwork on that. Right, but the underlying, I think, intuition behind this question is that, yes, we do have, it also is really important in this context, whether we're talking about clinical alexithymia or subclinical, because the small inherent factor in mild leads to a lot of subclinical alexithymia, people who do not reach threshold on the Toronto alexithymia on the TAS. So that's one of my guesses, that it is higher than expected as a comorbidity in ASD. One reason being the mild inherent factor. The other reason, and that's connected to this, but it's going back to Yonat's question, is that since the small inherent factor in mild autism has to do with the prefrontal not reading the insula very well, even if it's there, that already developmentally doesn't bode well for how the system is going to develop. So as me and Jeff like to think about it, there's an inherent risk anyway. So we think that this inherent risk manifests itself as a lot of subclinical alexithymia. The big question is, does it developmentally also lead to more comorbid? I don't know the answer to that. All I can say is what I said before. The comorbid ones looks like the comorbid ones in other psychiatric disorders and does not correlate with body agnosia. So I suspect this is the real thing. So I think there is still a good question of why is general comorbid alexithymia higher than we expect in ASD as compared to other psychiatric disorders, and I have no idea.
Okay, so that was why I started with that question, because I think that's important, particularly given that many of the people with autism also have other comorbid conditions. But now I'm actually going to read her question so that you will understand. This is the second question, and it is, if people with ASD have the inherent factor of alexithymia, that they don't necessarily feel they're bodily emotional responses. How do half of them not have full-blown alexithymia?
Right.
Are they interpreting how they should be feeling in the situation?
No, it has to do with the size of the factor. It's a really important question. Going back to the slide, no, this is a really, so I have to explain it again. That in mild autism, there is dyspraxia, but it's small. It took years to find it. There are episodic memory difficulties, but Dermot has to work for decades to document it. And there are small sensory issues. So there's every reason. So the body agnosia in mild autism is very small. It's about, I would say it's about the scale of the episodic memory differences. It's close to typical. That will not create the comorbid alexithymia there, okay? That's independent. What I don't know if the comorbid alexithymia, that's another interesting question, Corey, is how much of the comorbid alexithymia came from the additional comorbid disorders? It's a really good question. I suspect that's part of the pie, but not all of it. I think even when we factor in the subclinical inherent factor and the comorbid alexithymia that comes with other comorbid disorders, there is still a piece of the pie that is unaccounted for, but I might be wrong on that. But no, it's really important for me to say the body agnosia in mild autism is very small. Most people with mild autism can go to doctors mostly, and they mostly know if they're hungry, and they mostly know if they need to go to the toilet. It's a totally different scale. In moderate to severe, those are people who cannot locate pain in their body at all without compensatory strategies. And they cannot answer questions about types of pain. They're often, the worse the pain is, and probably the more endorphin is around, they can't feel any pain whatsoever. I'll tell you a story about moderate autism. I once volunteered in autism self-help camp, and we're talking, some of the moderate people are highly intelligent, a small minority, but that doesn't help. And a very capable woman in her 20s came to me and said, okay, when I'm sick, when can I go to an emergency room of a regular hospital and not end up in the psychiatric emergency room? It's a real concern. And we thought about it a lot, and the answer is only something that you can show. If you cut your hand, go to the emergency room and show your hand. But the moment you open your mouth, you will end up in the psychiatric emergency room, because the people with moderate to severe, when you have moderate to severe body agnosia, your attempts, the first thing that happens is that your poor attempts to describe your body always sound like impersonalization. You are describing your body from outside because there's no way to describe it from inside, and you're using very strange metaphors, and it's just really, really dangerous if they're not very socially savvy, very, very socially savvy. Those are people, or they have not been taught to shut up and show what's wrong with them. Anything that needs a description would land them in the psychiatric emergency room. So it's a totally, totally different scale of difficulties than the ones in mild autism. And that's just the way it is.
Thank you. I must say that that example was highly illustrative, and I appreciate it. I don't know that we have all come in contact with people who are that extreme, but I think that sometimes by describing the extreme, it does become clearer what it is that we're talking about. So I thank you for that example, and thank you for your explanation.
Any other questions?
I have one more question. If
No
there's
problem.
no other questions from someone who didn't speak yet.
Remember, I can't see anyone. Corey, would you like to field questions because I can't see the people? I can't hear you. You're muted, Corey. You are muted, Corey.
I got it. Thank you.
Okay.
That's Yonat who is speaking again.
No,
and
Yonat I can see, but Yonat was raising the question. She said she's a nice person, and she said, "Should I not speak again before others who haven't spoken?" And I can see the others who haven't spoken.
Yep,
So I
but
asked you to-
that's okay. If someone wants to speak, they will. And I think that Yonat's question will probably add and maybe bring someone else to ask another question. Please,
No problem.
Yonat.
So my question is actually stemming from thinking about the developmental course of being aware of our own feelings. So I would guess that if a mother speaks to the baby and says to him when he cries, "Now you're hungry," or "Yes, I know this is not pleasant," so maybe this is the way that babies start to be more aware of how they sense and feel. So with that in mind, do we know about anything that can be applicative or, let's say, help or train people with alexithymia, something like biofeedbacks or behavior?
Right, but okay. But again, this is why this is so important. We need to distinguish between the mild and the moderate severe, because in the mild, all right, there is just, you could train the brain to do it because the child knows that something is unpleasant. So then you can do biofeedback, maybe you can do mindfulness, all sorts of techniques that would increase basically awareness of your bodily states. The problem in moderate to severe is that you have nothing to build on. When I did informal interventions with moderate to severe kids, but with high enough IQ, okay, I would tell them, so how do you know when you are excited in a good way versus when you are afraid? Well, in both cases, your heart will pump hard. But when you are afraid, the tips of your fingers, and those are precise kids, you can't say the fingers, you have to say the tips. The tips of the fingers are cold, but if it's something happy, then your heart pumps. But the tips of your fingers are not cold. But and the crucial thing is that those kids, the moderate kids, need this objective description from the outside. And conversely, when you try this type of intervention on the mild kids, they get so bored. They get bored out of their mind because they are aware. They might not have a good name for the state, but they can read the state. They are not confusing physiologically being afraid and being excited. But my kids, the moderate kids, honestly do not know. They need to measure things on themselves from the outside in order to start the process that you were talking about, even with the mother. The mother of a moderate kid has no chance. There's nothing to build on. This is why
But when you use these techniques from the outside, does it help or does it always remain like it's what I mean to ask, is it like helpless? There's nothing to do with the inherent factor, or do we know of?
Let me bring you back to the slide about the inherent factor. It ends up as usual as a heap of compensatory strategies that are not flexible and do not do the typical job at all and go under my large heading of better than nothing. This is the way these kids do movement, like puppeteers. They move their body from the outside. There's this wonderful quote about perception from one of the moderate people who said, I walk on the street and I see trees walking, but I know the trees do not walk. So I know that there are not trees. Okay, there are no hallucinations. Those are people who have learned from age 0 that the perception gives garbage, a lot of garbage. So they're just not trusting their perceptions and they're correlating it with knowledge and with everything else. So perception is done by compensations, movement is done by compensations. These people are typically have some of them are certifiably amnestic because they don't have enough episodic memory. This doesn't happen in mild. They are amnestic. So they do memory by compensations. They do perception by compensations. They do motor by compensations, and they will do, describing their emotions by compensations. So in a sense, it's hopeless because you never get to any typical strategies, but it is much, much better than nothing.
So I would disagree with that, Dorit, because I can tell you, and Yona, in relationship to your question, that it depends what that individual person has to attach that compensation strategy to. Because some of those compensation strategies end up becoming incredibly useful, internalized, and for example, giving an example, when I once told a child how to measure the personal space that he needs to keep between himself and another person by the balatot on the floor, the first time he needed to actually count the balatot, maybe the fourth time he did, but by the 10th time, his eyes were measuring it automatically the same way as we measure the height on a stair. We definitely go upstairs automatically, but at one point, little children have to do it not automatically. So some people's brains can function with giving them some of those compensatory strategies will find a place and actually be incorporated into. I totally agree with Dorit that it's better than nothing. And we definitely need to realize and start there. But we also have to make those individual ways of explaining to them appropriate to the individual so that that individual can use that information as automatically and as internally as possible.
But Corey, I agree, but do you realize that with all those compensations, when if a child with moderate to severe body agnosia, after internalizing those compensations, he would still be reading his body from the outside and he would still end up in the psychiatric emergency room. If he's not
maybe and maybe not, because it really depends then how he's learned to, what words he's learned to use it. I am going to stop now because I think I don't want to do it. Does anyone have a last question for Dorit before we thank her? And I want to add one more announcement, please. A last question?
Yeah, I so you talk about the mild versus the moderate.
I don't know who is talking. That's my problem now.
Yeah, you can't. I can't turn on the camera.
Oh, okay. All right.
So you talk about the mild versus the moderate, and you speak it. I don't know if that's what you meant, but it looks like you speak it as though they're either mild in everything or moderate in everything, in all those 4 brain areas. So you can't be, you know, mild motor but moderate body agnosia or something like that. For you, it seems like
it's a very good question. You can. You do see them clustering, but not always. They do tend to cluster a lot more than you think, but not always. I think you can see it on the short sensory profile, you know, that there is one subtype that has moderate to severe difficulties in all sensory modalities, and another type that has mild difficulties in all sensory modalities. And there's no reason there as well. You know, some people would be worse on visual than auditory. So yes, it doesn't need to come together. It just does so often, not always. Fair enough.
Dorit, I must say thank you. I think that you have brought to life a question that is quite interesting, and we will invite you back because you began your talk by saying that alexithymia has something to do with identifying emotions and also impaired empathy. And we only heard one part of that story. At one point, we'll have to hear the other part of the story. But what you have succeeded in doing for us, אני לא יודעת למה אני מדברת באנגלית, מה שאת הצלחת לעשות בשבילנו, זה בעצם להעלות את העניין של להכיר ברגשות, לזהות אותם ולפעול לפיהם בתור אלמנט נוסף בתוך כל ההטרוגניות של האוטיזם עצמו. ואני כן חושבת שבאמת אנחנו מגיעים למשהו שהוא מאוד חשוב. השאלה האחרונה אני חושבת שעולה היא, האם באמת החוסר יכולת בעצם לזהות, לדווח על איפה דבר כואב, האם זה באמת אומר שאני בהכרח לא מרגיש את התחושה? And you could talk in English. The question was even in English. It just popped up while I was talking.
Well, those people cannot locate pain. They just cannot, it's not they cannot report to others. They cannot, there are compensatory strategies. They are weird. You can train the person, if it works, to not think and put their hand on where it hurts, and then look where the hand is. Like blind sight, but for pain, to circumvent consciousness, to force yourself not to think, to act fast. That is always important in blind sight, and put the hand and then look where the hand is. But it's definitely not a problem in reporting, because the problem is that you don't know where the pain is. The hand might sometimes tell you, and then you look at the hand and then you can report the hand.
Okay, toda raba. I really want to thank you. I think it was wonderful. And I think you actually, as you spoke, more and more questions came up. So it really is an incredibly new way to be thinking about some of the things that we see. And I just want to thank you. And I want to invite all of you to our next seminar, which will be on the 12th of January. And Dr. Einat Gal Michifa is going to talk about RRBs and other aspects of functionality. So we will do that again. And once again, I thank all the participants today for your questions and for being with us and your attention. And Doroit, I really appreciate your pulling together and making neuroanatomy something that we can respond to in almost all of the children that we see now. We talk about sensory things, but you brought it to life in how it affects all the other aspects of our brain functioning. So thank you very, very much.
Thanks everybody. It was fun. Bye for now.